Hello and welcome to class, all 0 of you. All of you are at the BRN meeting, and so that's a good thing. I'm excited to hear how that went, but it is very strange teaching to an empty classroom. But you know me, I can teach anywhere, and I like to talk, so I'll just get to talk to myself today. So let's get started and finish up what we were talking about last week on infectious disease, immunity and inflammatory response. I did add those slides you'll see here that we hadn't finished from last week. So here we are, immunizations, vaccinations. Let's talk about the side effects. We have the local reactions, which we already talked about, and we started on the systemic reactions, so let's talk about that. Systemic reactions, we can see anything from fever, malaise. We can have the syncope, vasovagal reaction. We talked about that last week. And then anaphylaxis was the one that we didn't quite have a full picture on and that I wanted to go over again. With anaphylaxis, I think it's on the next slide. Yes. So with anaphylaxis, some of the symptoms that we see is many times when I've seen patients going into this, they first start talking about itching. That's always one of my first signs. Also, they get short of breath. Sometimes they literally feel like their throat is closing up. And then you'll usually see things like wheezing and difficulty breathing. The treatment for this immediately is for you to come in with the drugs of choice, epinephrine and Benadryl. You've already given the vaccination, so you can't remove it. It's there, okay? So epinephrine 1 in 1,000, and we give 0.3 milligrams sub-Q to adults. And this is the standard treatment that we have ready. If you go to any vaccination clinic, we will have a dose of epinephrine and Benadryl ready to go. Benadryl is the other treatment of choice, 50 milligrams IM. Give it in the opposite arm of where you gave the epinephrine sub-Q. And so one you'll be giving epinephrine will be sub-Q and your Benadryl will be IM. And then of course you call 911 because this patient needs to go to a treatment center, needs to go to an ED and be evaluated because maybe you'll stop the reaction, but maybe you won't. So you give the meds, you call for help. Whenever there is a reaction that occurs, we need to fill out what is called a vaccine events reporting system. It's a piece of paper that I'll show you next week when you guys come in, where you describe what the reaction was, but also you have to write down what the lot number of the medication was that you gave, all the information about the manufacturer, the expiration date. So be sure that when you are working with your patients that you keep those vials or you've written them down when you administered them. That's the best, is when you give that medication, you have to write down that information, especially at Tri-City when we go in there and we have an immunization we have to give. They require you to input that information. So you'll need that for reporting. Okay, so what's the procedure for the immunization? Well, first off, you want to give patient education. This is what we give them is the vaccine immunization sheet called the VIS. And I'll show that to you next week when you guys come in. But you've used these before over at Tri-City. You print them out and you give them to the patient. You need to give this to your patient before you give them the immunization. They need to have read this and gone over it and had any questions answered. Then you need to get verbal consent from the patient. So far we don't need written consent yet, but right now we do need verbal consent. You need to talk to them about any allergies they might have had in the past, previous reactions, if they had an egg allergy. These are all signs that they might have problems with the vaccination you're going to give. Of course, you want to follow the vaccine instructions, read that, and make sure that you're giving it the right way and everything. Don't assume that you do know that. You want to give it in the dominant arm. For an IM, we typically give it in the deltoid for adults. And you want to document the lot number, manufacturer, expiration date, etc. You want to observe the patient for 30 minutes post-injection. This is where we talked about before. That's what the book says, that's what we say, but that's not what we'll see in clinical practice. Many times they just let the patient go. That is not wise. Medications available for anaphylaxis you need to have nearby. And so that, I believe, is on the next page. Let me see. Yes, here it is. So we have the site, the lot number, observing the patient for the 30 minutes, and then also having that medication immediately available for any reactions. Now, I've been at clinics where we've done mass immunizations where we would have one epinephrine drawn up and one Benadryl drawn up. But I've been at other ones that haven't. They've just had the medication right there with all this equipment there so you could draw it up really fast. I think it's smart to have it immediately available, especially when you're doing those large numbers of patients. But that's my personal experience, and that's something that when you start working, you'll see a wide variety of practice. And you have to decide what you think is safe. But you absolutely must have that medication nearby and ready for you to utilize. That would be negligent not to. Okay, now we're starting on infectious process and infectious diseases. Oh, I missed hypersensitivity reactions. Okay, I'm going to have to pull that up. I don't have that slide here. But let's talk about it. I know you have it on your printout. So let's talk about hypersensitivity reactions. The immune system is basically overreacting to the antigen, and it's causing harm to the patient. In reality, we rarely know at the time of the reaction which one of the hypersensitivity reactions that's occurring. I mean, sometimes, certainly when I see them having a reaction to poison oak, and I know what that is, I know immediately which hypersensitivity reaction, or if I'm hanging blood and they have a reaction, I know which one that is. But many times the patient just presents with the itching and the rash or different reactions, and so I don't always know what it is. You don't really need to know what it is, but by knowing which reaction it is, you can enhance the correct remedy that you use. And just remember that all of these hypersensitivity reactions are really an excessive immune response to an antigen. Okay, so let's look at type 1. I am so sorry I don't have these slides here. I thought I had this all lined up last night, but type 1, rapid hypersensitivity. This is the most common one. This is where the IgE is responding to the antigen. Too much of the IgE is responding, and so we get this acute inflammatory response. So the typical ones that we see this with are allergies. We'll get a local systemic reaction. Allergies such as asthma will respond this way. Allergic rhinitis responds this way. Latex, insect bites, and of course any kind of anaphylactic reaction to such as a medication, shellfish, dye. So, you know, when I look at this, I definitely get reactions to insect bites. I have seasonal allergic rhinitis. So I have this type 1 going on, and I bet quite a few of you do as well. In our collaborative care, the basic thing is to avoid whatever is causing this, whatever the antigen that's causing this overreaction. Sometimes that just isn't possible. I mean, for me, it's the seasons when the weather changes dramatically. I have a reaction to it. I'm not sure if it's the pollens or if it's the weeds or the trees or the grass. I'm not sure what it is that's triggering it, but it's impossible to stop the weather from changing. So I can't avoid it. But desensitization is one way that we can deal with this. Actually, when you get desensitization, it's people, what they'll do is they'll give you injections, an allergist will, and this increases your IgG response, and they give it in very small doses where they do this. Some allergists have just a wonderful formula that works, other ones don't. I've heard people say that they felt it made a huge difference. Other people I've said didn't make a difference at all. So I'm still out on what I think about desensitization. Antihistamines is certainly a medication that we want to consider for our patients with this. And then epinephrine is certainly the one that we would use for any anaphylactic reaction here. And so EpiPens, we'll typically have our patients carry EpiPens on those. And EpiPens are a wonderful tool to use to help our patients when they are away from us and they need to utilize. Welcome. So right now I'm at hypersensitivity reaction. So if you want to sit down, we'll go from there. I don't think I can pause it. Okay. That was type 1 hypersensitivity reaction that we're talking about, and unfortunately I apologize again that I don't have that slide up here, but let's go ahead and go to type 2 cytotoxic reactions. This is where the autoantibodies attack the cells due to a foreign protein being attached to them. So foreign protein is attaching to our cells, and so what ends up happening is our autoantibodies go and attack it. The best example I can give you for this is your hemolytic transfusion reactions. Hemolytic transfusion reactions, what happens is, for example, let's say that you are a positive person and you get B positive blood. I would hope that would never happen for you, but the B positive protein attaches, the B molecule attaches to your cells, your RBCs, your cells, and your body then will attack it. So what should we do? Collaborative care is that we should discontinue the causative agent, so whether it be blood or it be drug. Some other ways to do it is plasmapheresis to remove the autoantibodies. And let's see, that would be the best way. The problem is once this hemolytic transfusion really gets going, it's hard to stop. And so the trick is catching it right off the bat and being able to stop that blood. Even a drop, an extra drop of blood will cause more problems. So we want to stop that. Type 3 is the next type of hypersensitivity reaction. This is immune complex reactions. Now, this one is an example of typically of the autoimmune diseases. This is where the immune complexes form in response to excess antigens, and what we end up having is tissue and vessel damage. So the most common example that we have of these are arthritis, lupus, where we get this overreaction. So how do we take care of that? Collaborative care for our patient is, of course, try and discontinue whatever might be causing the damage, but sometimes it's not always obvious what that is. So basically we are doing symptomatic relief. So we're going to try and help our patient by just treating the symptoms, such as with arthritis, we'll try and treat the patient for the pain and joint damage that's going on, but we also will go into the immunosuppressants. The immunosuppressants will help to decrease that excessive autoimmune reaction. Type 4 is the delayed hypersensitivity reaction. This is where we have T cells that respond to the antigen due to a previous exposure. The thing that's interesting about this happens about 1 to 3 days after the exposure. So the most common one that we can think of right off the bat is TB exposure. When you go ahead and you inject that TB a mild amount of TB into the skin, and then within about 1 to 3 days we'll see that reaction if they've been exposed to it in the past. So PPD is a good example. Contact dermatitis is another example. Collaborative care for this is, of course, remove the antigen if you can, especially with contact dermatitis. If we know that it is a particular item that tends to make us very allergic, then we need to remove that if we know what it is. The other trick is going with corticosteroids and anti-inflammatory agents. So we kind of want to decrease that reaction. Type 5 is our last type of hypersensitivity reaction, and I really hate that I don't have a slide up here to show you these things, but I will go over those briefly with you guys when you come back next week. Stimulatory reaction is type 5. This is an autoantibody triggers an excessive response by a cell surface receptor. And the best example I can give you for this one, because we don't see it as often, is Graves' disease. This is where there is a reaction in the thyroid, and so it triggers all this excessive response. And so the best way is to remove that specific tissue that is causing the problems. And in this case, with Graves' disease, we remove the thyroid gland. Another way to deal with this is immunosuppressants. Okay, so I now have a slide to go to. So we're going to talk about infectious disease. And I do finally have one student in my class. Yay! So I have someone to talk to, where before I didn't. So let's look at the infectious disease. Let's see. Why do I need to know this? Well, one of the things that about everything that we're going to talk about relating to infectious disease today is we're going to utilize the information to help us to be able to treat infection more effectively and also to protect ourselves. So we're going to use the chain of infection to protect and prevent your patients from getting infections. We're of course going to talk about transmission precautions, which are absolutely essential to prevent the spread of these diseases. If you know how a disease is spread, you can intervene. And I see a lot of times I'll talk about it as I go through the lecture, that I see people being afraid of a disease or being anxious over a disease that they're taking care of in a patient. And if they understand the transmission, then they don't have to get so freaked about it, you know. So I'll talk about that when we get to some of those. And then we're also going to talk about what to do for a patient with an infection. Specifically, what can we do to help them fight the infection and to protect themselves? Okay, so let's start with infectious disease. The first thing is the chain of infection. I know that you guys went over this in semester 1. Semester 1 talked to you about this chain of infection. It is so important to know this when you are looking at a disease that's infectious, so that you can make a decision on how you can intervene. So let's look at right now, and I think this is one of the reasons why we're going to talk about Ebola later on. We don't know how the Ebola is happening, and so that's where the problems are occurring right now. Until we find out, we do know how it's transmitted, but we don't really know the reservoir going on, and we don't know about the susceptibility. So we're getting more and more data every day about it, and as we get more and more of this information, we'll be able to intervene more effectively. But looking at the chain of infection, briefly review, let's see. Okay, so let's look at this. So if we know what the organism is, and we know where it likes to stay, then we can get rid of that, if we hopefully. Or let's say that we figure out how it gets away, then we can maybe prevent it there. Mode of transmission is the most common way that most nurses will intervene. We know that it's coming, we'll do it by fluids, or it's by airborne, or by droplets, and how it gets in is important for us to do. Host susceptibility, we're going to really focus on today, on how we can help ourselves and our patients to not be so susceptible to the different infections. Okay? So, Moving on, let's look at how can we control the route of transmission. Well, certainly we want to look at the 2 tiers of isolation precautions. We look at standard and we look at transmission-based precautions. Standard, of course, is universal, which we need to practice all the time. We use it with all of our patients. Any time that we come in contact with any blood, body fluids, secretions, excretions, except sweat is one that we do not apply this to, non-intact skin or mucous membranes, we need to be protecting ourselves and our patients. When it comes to transmission precautions, we need to be used with a patient. We use this with a patient where we know exactly what the disease is, or we suspect a particular infection, okay? So we are going to look at the 3 different types here. This should be review, I hope, from last semester, but I know that it goes into your brain and it goes out pretty fast because we give you so much data. But the more you are practicing this in clinical, hopefully the more it's solidifying. So there's 3 types of precautions: the airborne, droplet, and contact. Airborne, the way that we can control any infections that are airborne is by putting a patient in a negative airflow room. This is going to keep the oxygen from leaving the room. So you'll notice at Tri-City, certain rooms have that. I believe right now it is 85 and 87 has that in the pavilions. Masks, we want to put in place the N95. That's that very thick one that you can get fitted for. And then also glove and gowns should be enacted for your airborne. Droplets, that is when we have a patient that has a droplet precaution, we know that that droplet can go 3 feet. So we know that we're safe 3 feet away from the patient. But if you're going to come within that 3 feet radius, then you need to wear a mask and goggles. Contact precautions, we get in contact, we have this a lot at Tri-City. We need to wear gloves, gowns, and you need to always be considering what's contaminated. And that's what always cracks me up when we go into patients' rooms. You know, we don't always think about where they are contaminating and is it getting clean. And another thing that is rather concerning is the number of patients, families that go in that don't maintain any precautions. And so that's very concerning to me as well. I don't have an answer for that yet. So let's look at some different examples of PPE. What is our PPE? Remember what that personal protective equipment? Okay. So first thing, we're going to talk about what should you do as far as when you go into a room, what's the first thing that you put on? And so you'll see I have number 1 here. The first thing you put on is the gown. Okay. And then what is the second thing that we put on? The mask, okay? And the third thing that we put on is the gloves. That is the order that the CDC says that we need to use to put on our garb, our PPE. And this is important that you use it in clinical and that you remember it. This is the order that it should be done. So I know Marty really drills this into you, so hopefully it's still there. Okay, now when you go to take the PPE off, what is the order of that? Do any of you remember? What's the first thing that you should take off?
Gloves.
That's right, let's go here. Well, wait, before we get there, let's talk about this guy. What do you think about his garb? Do you think that he's okay? Is he protected?
How he has everything on? Are his gloves over his gown?
Not really. It's hard to tell whether the sleeves are longer than his gloves, and so we're not seeing that. But yeah, the gloves should go over the gowns. That would be ideal. But I'm concerned about,
Neckline?
yeah, that whole area there is certainly uncovered. So when he takes all this off, that's still really contaminated. Could have gotten contaminated. So I wouldn't be too happy if I saw this. Do we see it all the time? We do. Isn't it amazing that we survive all the things that go on in the hospital, even though we don't maintain things the way we should? Let's look at this. Oh, now this is where you said, let's take the gloves off first. Absolutely right. And you can see with this patient, with this worker, you can see that truly he does have the gloves over the sleeves. So perfect. What should we take off after the gloves? I'm really, since I only have one student here, he's being very called upon.
Well, I read the thing you put online, so it kind of got itself mixed up because the mask that they had a eye shield that goes over the mask.
Ah.
They were saying after the gloves to take off the eyewear, and then after the eyewear to take off the gown, and then after the gown to take off the mask.
Oh, no, I hadn't heard that. I'm going to have to check on
So
that.
I thought that was kind of weird because usually the eyewear is attached to the mask.
It is.
A part of it. I just think it's old.
A lot of hospitals, and I think most of the ones that we go to, they have goggles. So they're saying take the goggles off first, okay? So, but
For me personally, I just take dirty off first. Your gloves are your dirtiest.
yes.
Your gown's your second. And then I wouldn't ever want to touch my face until all that stuff is off, so then I take my mask off last.
And that's not what the CDC said. Well, yeah, and that is what the CDC says. You're right. So, and that's a good way to think about it. So, but the trick is also, and I know Marty really stresses this, is the way that you take it off, so that you don't recontaminate yourself. So we take off the gloves. I agree. We then take off the gown. That is very important to be able to touching the section, because your hands are now clean. You don't have those gloves on. So you need to just touch the area that is going to be non-contaminated, and then fold over the area that is contaminated. And then lastly, you take off your mask. And this is really, I see so many people, when they take off their gowns, they just pull from, and they don't have any awareness of where the dirty is, or they take off the mask and they have no awareness of where the dirty is, and so now they've contaminated their hands again, and now we've just spread it when we go out. So we have to be very focused on that, especially as we start getting into more and more diseases that, I think by the time I finish this lecture, you guys are all going to be so scared to death of some of the infections that are coming through in the viruses that we don't have any cures for. And I went to a conference last year, and the odds that we're going to be able to fight many of the viruses over the next 10 years is going to be very low. They're not coming out with any new antibiotics, and the viruses are mutating faster than we can come up with a medication.
Everyone has C. diff.
Oh, yeah. Well, and that is not really what we call an infectious disease. That's a super infection, and we're going to talk about that one too. So that'll be a good one for you for your job, and I appreciate your personal experience. Oh, and then last, of course, we do need to wash our hands. Always want to do that. Now, we know, though, that hand washing is very effective and very necessary, especially for C. diff because of the spores. But we also know that the dry soap is also just as effective. The waterless soap is just as effective. The research has shown it's just as effective, except against spores. So, okay, so what do we think about this lady here? Do we think that she's ready to go into a room?
For her gloves.
Except for her gloves, exactly. Okay. So a little bit showing here, which would be preferred not to be showing, but some of these gowns don't quite work. Here, this lady here is being next to this patient. It's a droplet precaution. So basically, she doesn't want to inhale or get them into her mucous membranes. So that's why this is good. Okay, let's talk about host factors. Host factors, I think I said it wrong, is the many ways that we can protect, our body protects us against virulent pathogens, and many ways we put ourselves at risk for pathogens. So let's first look at the first one we talked about last week, which was the physical barriers. Those physical barriers we already covered last week in lecture about, how our body physically protects us. Our skin protects us from different items, as well as we also have, the cilia, and the, 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 different things in our body. I'm not going to go into it because I went through it already once before last weekend, so I'll get off track if I go too much into it. So refer to your lecture from last week about that. We also talked about how our body's immune response and inflammatory process also are things that that our body does for us to protect us against infections and antigens. But and also our nutrition is a major factor. We talked about how essential it is to have a well-balanced diet and not to be malnourished in protein, how that can really impact our ability to fight infections. So now let's look at specifically pre-existing diseases. Pre-existing diseases will increase the risk to the host, to our patients, to ourselves. So patients that are taking any kind of glucocorticoids, steroids, are more likely to have problems because that whole group of drugs, the mineral corticoids and the glucocorticoids, all of them are going to suppress our immune response. And so that does not help our patients. It also suppresses the inflammatory response. People with chronic disease may also be immunocompromised. So we know that patients that have like diabetes, peripheral vascular disease, are much more at high risk for infection because of impaired circulation. Health habits is another factor. If a patient is using drugs or such as alcohol, we know nutritionally they're compromised. If they're smoking, we know that they have compromised some of their physical barriers by causing problems in their lungs. So these different factors can be really a deterrent to their good health. Psychological factors can also be an issue. Stress. They have found in lots of studies that stress releases cortisol, which is our corticosteroids so that's going to suppress our immune response. This also then goes on to suppress the function of neutrophils and macrophages. So we know that our ability to fight infection is going to be very compromised, and the ability to clear our body of bacteria is going to be compromised. So definitely stress is something that we need to consider and intervene with. When we do our lecture on shock and stress, I'll go more specifically over different things to do with stress. Age is another issue. Our patients that are very elderly, they say that after the age of 60 that we see a decline in immune function. So our neutrophils diminish, as well as our phagocytosis is also compromised. So we know our patients are, anyone that's over 60, we automatically assume that they have some kind of compromise of immune function. Some patients seem to have it more and others don't. So that's, I think, is probably a compromise of genetics and good health and taking good care of themselves. Babies are another group that we need to worry about in host factors. That is, a baby still has their immune system that's developing, and so they are vulnerable. Surgery is another one. Procedures. Surgeries obviously give us a risk for infection because we are doing procedures that are penetrating the skin. Just by starting an IV, we have penetrated the skin and broken down that natural barrier, that physical barrier that we have there. And then if we add on that we cut into the skin or we put a Foley catheter in place, all these things are going to cause our patient to be more at risk for that entry of that pathogen. Okay. Next thing I want to look at besides host factors is also the stages of the infectious process. And I find this very interesting, and especially if you work in pediatrics. And of course, when I did school nursing, this whole thing here is so revealing on how a disease will progress and how you can predict some things. So let's talk about the different stages. There is incubation, prodromal, acute, and convalescent. At incubation, this is the time between when the pathogen has invaded and the onset of symptoms. So let's say that today I had some little kid come up and give me a big hug, and that child has measles, and so that pathogen has now come to me, and now, but I don't have any symptoms. So this is the incubation period, which makes sense. I've gotten the pathogen, but I don't have any symptoms yet, okay? Now, the organism is established, but there are no symptoms. And this is predictable how long this will take. Each disease, if you look it up, that we know about, Ebola we don't know yet, but the other ones we do, we can predict how long it'll take. In the books, it'll say it takes 2 weeks, it takes 10 days, it takes 3 days. And so this always cracks me up because when I worked in school nursing, somebody would say, oh, she got measles from that little girl that had measles today. And I said, well, okay, when did you come in contact with the child? Today. And when did the measles come? Tonight. Well, I can tell you it wasn't that child. Some other child, maybe the child that girl got it from. But we can predict by knowing the particular diseases. My daughter got exposed to mono. She comes home, tells me. I said, well, how did you get mono? Because I know how mono is spread, so you'd have to drink or kiss, pretty much. So I thought she had a boyfriend, and this was not a boyfriend. But anyways, so she was kissing somebody else. I love my daughter. She says not to say anything negative about her, but she just had such an interesting high school years. Anyways, so she comes home and tells me that this kid is in the ICU with fulminating mononucleosis. So he's in really bad trouble, okay? So he is having a terrible time, and she is scared to death that she's going to get it, and rightfully so, because we know that she has kissed this guy, and we know that she could have had exposure to the pathogen. So I go look up the mono, and I think the thing was 3 weeks was the incubation. So I said, okay, 3 weeks. So I counted out the 3 weeks. 3 weeks was going to put her into the first week of her first week at college. And I went, shoot. You know, so you're going to be away, first off, and if you come down with mono, that's the end of college. I mean, you're going to be, at least for that semester. I was so not happy. But there was nothing I could do. Thank God she didn't get it, so we're good. But, you know, these are things that you can't predict, and so you can talk to the person and say, okay, it definitely wasn't that person, or, you know, whatever. Okay, the next stage of this is prodromal. This is the initial stage of the disease. This is where we see the earliest symptom. Now remember, the earliest symptom is usually nonspecific. You kind of don't feel so good, you know? I could always tell with my daughter that she was coming down with the disease. She would come in and she'd sit right down next to me and kind of cuddle me. My daughter never did that. And so I'd look at her and go, why are you so quiet and why are you cuddling, you know? And that was the beginning. And the next day she'd be sicker. You know, she'd be sick. Specific symptoms by then. Acute is where the symptoms are fully developed. So this is if we were talking about something like measles, we would actually see the rash and it would be fully developed, and the child or the person would be very unhappy. And then convalescence at the end is the recovery, where they are now, you know, and with measles, they've crusted over, and they're starting to heal. So this is a logical progression. Every disease you can look at and find out what the incubation is. It will tell you what the early symptoms are. It'll tell you what the acute symptoms are and how long it takes to convalesce from these. And so you can find all this out and predict. Let's look at the next phase, next item that I want to talk about in infections. This is the emerging infectious diseases. Definition of this is the infectious disease that has newly appeared in the population or is rapidly increasing in the population or the geographic range. So we have quite a few diseases that we can talk about today. I pulled a few of them out to talk about. This particular website here is the CDC's area where they talk literally about the emerging infectious diseases, and it is a long list. which doesn't make me happy. Right now, what we have been seeing newly appeared in our population is a recombinant HIV. It's a cross between two strands of HIV. Two strands of HIV. Actually, I don't know if you know this, but there's 60 strands of HIV. Probably since I've written this down, there's more. And this particular HIV has become more aggressive over the last 5 years. And so we're worried about that one. Luckily, we have been controlling HIV more effectively, but still there's certain areas in the world where they aren't. Russia is one area going into China that has not had a good control, as well as in Africa there has not been good control. And it has to do with the way that the population moves geographically, and also it has to do with the way that certain belief systems. And so the education has to be in those areas to try and help keep this disease from growing. There's also rapidly increasing diseases in incidence or in geographic ranges. These are typically what the CDC has been saying are ones that are resistant to the meds. And we're seeing malaria starting to be resistant to the meds, as well as TB and bacterial pneumonia. So these are different ones. Like I said, by the time we finish this discussion, you're going to be very unhappy. I'm unhappy. So let's look at one that's coming out right now that we have all been very worried about. I saw yesterday that President Obama has decided to send emergency workers, military personnel to West Africa to try and help stem this outbreak of Ebola. So let's talk about this disease. At this point in time, we have not had a problem with Ebola in the United States, but that is certainly not true for Africa. So Ebola, they're describing it two different ways. I've seen it said Ebola HF is the way it first came out, and that is considered Ebola hemorrhagic fever. But I am seeing now more and more where they're saying EVD, which is the Ebola virus disease. So I'm having a feeling that that's where they're going to stay with the term, is the EVD. This particular disease has a warning level of 3 by the CDC, which says they want you to avoid non-essential travel. One of the biggest problems that we're seeing with this particular disease is that there is a 60% fatality. Now this disease has been around for a little bit, but this last outbreak has been just really devastating and dramatic. And so the CDC has said that we have had, and I never ask you numbers, okay, unless I tell you you need to know this number, because they change. But the last data coming out is that we've had 5,000 reported cases and we've had 2,500 deaths. So that's kind of a 50%, although CDC was saying they're seeing more of a 60% mortality. The problem is we have no vaccine and we have no treatment. And so that is where the real issue comes with this particular disease. Luckily, the transmission is through bodily fluids. So you have to have contact with that patient to get the disease. And so that really helps a lot, because a lot of the things that we worry about, the diseases that we worry about, are the airborne ones, because they can, with the way that we have global travel, it can be spread very quickly. So this one we've been able to control and keep more into one area. They're not allowing people that have visited this area to come into the United States, or they're looking for any kind of symptoms that they're having, and so they've been able to control that. But the problem really is there's no vaccine and treatment. I was reading yesterday, because this is one of those diseases you kind of have to be reading right up to the day of the lecture, is that there is a vaccine that's supposed to be tested starting this month, but I haven't seen it or heard anyone saying about it. They do have several companies that are working on a treatment, but one of the biggest problems is they really don't completely understand how this particular virus has come to us. So I think they were believing originally it was from bats, and that some people in Africa eat bats. So they believe that that was the way that it was coming, but they're not sure. So that makes it very difficult. It's contagious when the symptoms are present. That helps us quite a bit. Unlike our HIV, HIV can be in a patient, in a person, and can transmit it to another person, and they don't have the symptoms. So this is very scary about the HIV, and that's why it was such a difficult one to control. But this one, at least we know they're contagious when the symptoms are present. We know it's a bodily fluids, and so we can control it. That's why they did that lockdown on that one city in Africa, and the citizens were so upset, but it was so essential to try and keep them quarantined. Okay, symptoms usually occur about 8 to 10 days after exposure, so we know that incubation is 8 to 10 days, right? So if I went to Africa today and then I wanted to fly back, you know, I could 8 days later bring that disease into the United States. So we're going to be looking at those incubations. The symptoms that these patients have are fever and aches, very bad diarrhea. Then they have the hemorrhagic eyes. That's where this hemorrhagic fever name comes from, is that they literally have the hemorrhaging at the end. Let's see what else. The big reason why Obama sent help, and you can do an argument either way, but one of the main reasons is that they believe the World Health Organization is saying that this disease is going to double every 3 weeks. So if they have 5,000 cases right now, which they don't, I don't know how many cases they have right now, but how many they have right now, we can double that in the next 3 weeks, and double that number again in 3 weeks. So you can see how some people feel that us going in to help now is too late. But at the same time, we could have an ethics discussion here on this one. So what can we do as far as us here? Like I said, we don't really have a vaccine that's really come out yet, but they're working on it. What can we do is one of the things that we need to be aware of when a patient comes into our area with any kind of symptoms of fevers and aches, which is so vague, diarrhea. We need to be asking the question as they come in the door. Really, the ED needs to be asking these questions, and the admitting doctor, have you traveled, and where did you travel? So we're really looking at that right now to control that. Okay? All right. And then, of course, if they have any kind of fluids, we need to be doing our precautions as always. And that's why you always have to assume, I always assume a patient has the worst disease possible whenever I deal with any of them, because some patients don't tell us what they have, and some people don't know what they have. So we have to treat it that way. All right. Another disease that used to scare everyone a few years ago, I don't know if you remember the big controversy with influenza. This seems like nothing now after we look at Ebola. But influenza is also known as the seasonal flu. We also call it flu type A, flu type B. This is a contagious respiratory illness caused by the influenza viruses. This is a seasonal flu. It is not the stomach flu that everybody will talk about, or the stomach virus. The problem with the influenza is that it actually spreads in 1 to 2 days. So that's got a really short incubation, doesn't it? So this is a disease that you can come in contact with, and you'll be down with it the next day or in the second day. So that makes it difficult to control too. But it is preventable. But despite that, it's the 7th leading cause of death in the United States. It kills about 36,000 Americans per year. Unbelievable, huh? So Let's look at the swine flu because we are coming up to the season of that. It's also known as the H1N1 or the H3N2 variant. That's the new one that's come out in the last year. The history of this and the reason why we get so freaked out about influenza and why they had such a big deal about it a few years ago is this is the same virus that killed all those people in 1918. That's in 1918 they had 30 to 50 million deaths from this disease. So it is, and the other reason that we get so freaked out about it, why the World Health Organization goes, is because this disease likes to go after young people. It goes at the 20 to 40 range. We're so used to most of our diseases killing our elderly or an infirm or vulnerable populations. Not this one. This one can go after our young patients, so young people. So that's why they got so freaked out when Mexico had that outbreak. So how is it transmitted? It is transmitted by droplet, so it's a 3 feet range. But the problem is that if it gets on surfaces, it can stay there for 2 to 8 hours. So let's say I cough all over this. Now, you didn't come near me, so you didn't get exposed to it, but I coughed on here. The next teacher comes in and is working on this desk and now has gotten, rubs her face, rubs her eyes. She's now gotten herself exposed to that because that surface still held it. So that makes it a little complicated as well. It's contagious 1 day before the symptoms, and it's contagious for 5 to 7 days after the symptoms. So, wow, that's a tough one to control, isn't it? So that's why the WHO got so nervous, and why I would get nervous as well. Let's talk about the symptoms that this disease has, and it's worrisome as well. The first symptoms that we get are flu-like symptoms, and then we go into primary influenza pneumonia. So the first thing we get is the pneumonia, okay? It's just the viral pneumonia. The problem with the viral pneumonia with this particular virus is it develops very rapidly, and it causes necrotizing bronchitis. So it literally is eating up your bronchial. So that's why we lose these patients so quickly. And I've seen a lot of patients like in the 40s, 50s, I shouldn't say a lot, but you just don't expect your 40 and 50-year-olds to go down from this, and they do, and die. The next thing that happens is let's say you don't get that one, you get past that one and you don't have any problems. The next problem that you have to deal with is about 4 days later is the secondary bacterial pneumonia. So then first off they fight off the viral pneumonia, or they don't get it, it doesn't develop, but they're still not out of the woods because they still could get that bacterial pneumonia. And that, like I said, occurs anywhere from 4 to 14 days after the flu symptoms. So that can also get them. And that's typically what we see the most of when we're working in the hospital is this bacterial pneumonia that they've gotten. Treatment for this is isolation of the patient, doing droplet precautions. We, of course, want to have those N95 respirators. Let's see. I think I have it on another page, but it is that, not the cheap one, but the good masks. We want to do strict hand hygiene, and most of all, we want people to stay home 24 hours after the fever is gone. So when we have somebody, let's say ourselves, we are sick with a flu-like symptoms, and we have a fever, we need to wait 24 hours after the fever is gone before we come back into the population, because otherwise we're just spreading the disease.
Why do you use the N95s? Those are the airborne precaution masks for a droplet precaution.
And I'm totally going what CDC said, so I'll follow up on that and find out. One of the things that I did notice about some of the information, and I just find this in a lot of nursing and medical things, is conflicting information. So you'll sit there and go, well, I thought this was droplet, but you're treating it like airborne. Or I thought this was droplet, but you're treating it like contact. And so it's almost like throwing everything in the kitchen sink against it, and so I've really tried to look at it and try and find specifically, but I haven't always been successful. But CDC is usually my most reliable source. They don't tend to throw everything in the kitchen sink at it. They are usually pretty specific. So I'll go back and double check on that. But what I found was that they were recommending that. So I'll go find out. I'll double check you and come back, okay? Strict hand hygiene, stay at home. Okay, medications. There are some medications out for this disease. There's the neuroamniodase inhibitors. But the problem with these particular medications are that they're needed early. So as soon as I get the flu symptoms, I have to, within 48 hours, I have to take this medication for it to be effective. And we found that people were coming into the ED during this time and they were giving this disease if they could definitely. But let's face it, when you have the flu, you don't tend to go in until about 48 hours later. Most of us don't. We kind of just lay there and hope it's going to get better. By the time you realize it's not getting better, it's probably outside of the window or pretty close to the end of the 48 hours. So, but the other thing that they found out about it is when they gave this particular medication, it only decreased the length of time that you had the disease by 1 day. So you're still going to have it. So let's say you were going to be sick for 10 days. It would make you only sick for 9 days. So, you know, it's not, they didn't find it to be as effective as we would have hoped. Okay? Let's see. Other things, let's see, let me see if I have it on, no I don't. Okay, let's go back to this page. So medications, also other things that we can talk about is the vaccination. So we should all get the vaccination. Anyone that is pregnant should get the vaccination, healthcare workers, anyone from the age of 6 months on. They are finding that still children are at risk and we need to give these medications. They're really recommending it for anyone with any comorbidities. And it really does seem to really be effective. We saw a huge difference in the amount of healthcare workers that were getting sick diminish since they've done really the mandatory. It's as close to mandatory as you can get. If you don't get it, then you have to wear the mask the whole time you're working on the floor, and most people don't want to do that. You will see I'll usually see a couple in the entire hospital that are doing that. But most of us are getting this vaccination, and most of the patients are not. I've seen a huge decrease in the amount of people. Have you seen that at your job as well?
Yeah, you rarely see someone wearing a mask because they don't want to take the vaccine. It's maybe it would be like a volunteer.
Yeah.
No.
Well, there's one person up on the floors with us that does, and then there's another person down in the OR that does, and I don't know what their reasons are. Sometimes it's because they're immunocompromised and they don't want to do it, although there's an argument to say you should get it. And then there's others, religious beliefs or beliefs that vaccinations are not good. And so it's their belief system. Sometimes that's the issue. And they make that choice. But I have seen, it doesn't seem that we've had as big a problem with this as we did before. Okay, let's go on to the next area of infectious diseases. Let's look at healthcare-related infections. These used to be called nosocomial infections. So in some books you'll still see nosocomial infections. And they also call them HAIs. These are any kind of area where they have, what does the HAI stand for? Hospital-acquired infections. So that's another initials that they're using here. Why can't they just pick one and stay with it? Anyways, so definition, this is infections that are occurring during hospitalization. And it is defined as being 48 hours after admission, 3 days after discharge, or 30 days after surgery. And they will then say it was related to, it was a hospital-acquired infection.
Do they they consider incubation periods for things that they're getting infected with? You said if some are
They
like
should.
5 days or several days, and it's kind of like the 48-hour doesn't apply.
No, that's absolutely true. You're absolutely true. So it all depends on what the disease is. So they would have to culture or find out what the bacteria or virus is and then make a decision if that was possible. Absolutely. Good point. So what are the statistics on this? And you know, I never test you on statistics, but 5% of all hospital patients will get a hospital-acquired infection. They have about 20,000 deaths per year in the U.S. from this, and it costs us about $5 to $10 billion per year as a result. It increases the stay for our patients by 7 to 9 days. So this is important. I mean, not only is it horrible that the patient has this extra infection on top of what has happened to them, but the extra cost, the extra time off from work and good health, very important that we try to minimize this. So what are the most common hospital-acquired infections? And then we'll talk about how we can prevent it. I had a really interesting seminar that I went to that talked about all the different types of hospital-acquired and what we can do. Actually, what organizations have come up with plans on how to fight these. So let's look at the first one. The most common one is UTIs. And of course, the most common culprit of our UTIs, you can see there, of our urinary tract infections is, of course, the Foley. So they account for about 34% of all infections. So how can we prevent these? Well, certainly how we put the Foley catheter in is essential. And you're going to see in clinical practice the rules that we have for aseptic technique go out the window many times. And we should never compromise in that area. However, for example, some of the biggest problems we've had, I've personally had, is when you're trying to do a catheterization on a woman that's very large, and let's say in this one particular case that I struggled so much was she had a broken hip. So we had to try and open up to be able to visualize by just the one hip going open and the other one staying the same. And we were causing a lot of pain for her, even with that. And then the other thing is that she also didn't have her meatus where you would normally expect it, okay? So it was lovely when you go in on a female and it has the urinary meatus right below the clitoris. But the reality is many women have it, not many people, I don't even know the percentages, but a certain percentage will even actually have it inside the vagina. That's really hard to find it. And also it's just a dimple. And if it's a large woman and you're not able to visualize very well, it makes it more difficult. So I can see why this gets compromised, but we have to really work hard not to compromise that. The best thing would have been to do for that particular woman in hindsight is we should have gotten her in for the repair of the hip, and when they put her under, then we could have been able to, she wouldn't have been in so much pain, we could have then visualized better in that hospital, in the surgical environment. But anyways, the other thing is pneumonia is another common health acquired, hospital-acquired, healthcare related. And you'll see there, it's the other big one up there. I don't have a percentage on this. But what can we do for our patients with pneumonia? Well, basically, the minute I hear, when I do my head-to-toe assessment in the morning, and I hear diminished breath sounds or anything going on, that's the minute I'm going to start doing coughing and deep breathing, ambulation if possible. Try and minimize the amount of narcotics that I use because that tends to make them not deep breathe as much, and using the incentive spirometer. Going back, I forgot one thing else about the UTIs. We talked about doing good technique when we put the Foley in, but also the other thing that we need to make sure is that the Foley catheter has the full, all the way down to the bottom, that there's no kinks, that it remains closed and secure, that we don't let it go open at all, and that we discontinue it as soon as possible. So this is one of the things that you'll see with the script policy is that surgical care improvement project, that we are discontinuing the Foley 1 day, 2 days max after surgery. And that's to minimize that amount of time. And so, in fact, one of the students, she's not here, but she did some really good education with her patient. Her patient didn't want the Foley catheter to come out. She wanted to go home with it. It was post-surgical. And I believe it was Aubrey, correct me if I'm wrong, Aubrey, said to her, no, that it's really important that you get it out sooner than later because of the risk for infection, and it's better for you to have it taken out now so that we can make sure that you can urinate, and if you can't, we can intervene, whereas if once you get home and we have you take it out, then it's going to be more of a problem. So great education. I was very excited about that.
When I did home care for 5 years, the quadriplegic patient I was with, he had to have it in all the time, so I saw the worst infections that you can get with those. You got a lot of calcium deposits building up, which would cause
absolutely
clogs for the catheter. So it was a nightmare when it came to his catheter, because he had to keep it in, and just, I mean, I saw every infection you possibly or deal with him.
That's a great example. We used to leave Foley catheters in with our patients forever, especially in the sniff and especially with the quad. And then you get that sedimentation,
Your
and
body tries to fight against it, like you were saying, with your antibodies and everything. So it became
a problem.
Yeah.
And now, so some people, what they would do is they would irrigate it on a regular basis. They would change it every 30 days. But we have found the best way to do it is to have a condom catheter. So the condom catheter is much more effective and actually works for your quads, so that then you're not having as much, and you just have to be really watching to make sure they don't get in trouble as far as retention. So did you guys ever try?
He actually did a procedure to cut the meatus, to cut it, he cut it horizontally, and he cut it or up and down.
Oh,
so,
wow.
So it would just, I guess, be an easier insertion and less, yeah, I know. So.
Oh, my goodness, that wouldn't be a choice I would have expected.
No, so I thought that was interesting. And the condom catheter, his skin was really sensitive. Like, he actually went through Stephen Johnson syndrome, so he was terrified to have anything on his skin. And, like, I was dealing with that, and just skin just sloughing off.
And they were sure that it was a skin reaction and not an antibiotic reaction for the Stephen Johnson?
They were trying to rule out things for a really long time, but he was very hesitant to ever use steroids until he got the Stephen Johnsons. Then they were throwing everything they could at it and just trying to knock it down. Then he was on steroids at that point.
Interesting. Well, he sounded like he was a very interesting case. And the nice thing about home care when you do it, not that I did not like my experience in home care, is that you're focused on that one patient. You get to see all the things that are done for that patient, and you can kind of mull and think about it. And I think you really get to do some good problem solving. And so I bet this was a very interesting case for you. Yeah, interesting. I would not have gone that direction with the meatus at all.
Yeah. That's the only time I've ever seen that.
A suprapubic catheter is another one that they put in. Anyways, we digress, don't we? Okay, all right. We could solve the problems of the world if we just had enough time. Okay, so going on, let's go to the next slide here. So the big trick about hospital-acquired infection is prevention, and you are the most important person for controlling this and preventing this. And this begins with us and the healthcare workers doing good hand washing. Absolutely essential that we do hand washing before and after we go into rooms. My basic expectation is that every student, when they walk into a room, does the waterless soaps and in and out. And not doing that is just not okay. It's reason for failure, really. So if I see people not doing that, and it's a rare day that I don't see a student do it. So You guys are well trained. Good. But remember that hand gels do not destroy C. diff, so we have to do hand washing when we're in those rooms. Cleaning of the equipment and the rooms is essential. One of the seminars I went to last year really talked about how essential it is that the department that cleans equipment, our housekeeping department, how essential it is and how minimized it is. You know, we do, how essential they are to cleaning. We can tell how well rooms do based on the cleaning, and yet they don't pay that department very well or equip it very well in general. Aseptic and sterile technique is essential that we maintain in the areas that it needs to be done. And then we also need to talk about transporting patients. And if you click on this particular site here, transportation of patients, you will see a video about that they produced, it's in a southern hospital, I believe, on how germs are transported from room to room and floor to floor. And it's a very good video. It's not very long, but I would recommend watching that. Room selection is another way that we can prevent hospital-associated infections, and that is by making sure that we put like-minded problems together, our MRSAs together, our C. diffs together. Better yet, have private rooms. That's always the preferred. Let's look here. It's a picture of how these can be transported from room to room. One of the things that really impressed me when I was in nursing school is I went to a real quickie little, it wasn't a post-conference, but the infectious disease nurse there at County had a little in-service. And so we went in to do it, and as we walked in the thing, she made all of us open the door and come in. And then she proceeded to do a whole thing on catheter care and everything, and so we're all around the thing. And then at the end, she turned off the lights and she turned on the blue light, and she said, "This is what you know, the doorknob was, I can't remember if she had the doorknob with the stuff or if it was the Foley catheter that at the bottom with the tubing." And she said, "This is," and we had handprints all over, blue everywhere. And I just went, oh my God, how much I can move things from one place to another. And of course, in those days, we didn't use gloves very much. So I remember us once having a patient with shingles, and everybody on the entire floor came down with shingles as far as the healthcare workers. And I was the only one that didn't. I don't know how that happened, but I didn't. But from that point on, everybody started wearing gloves. And so, gotta wear gloves. When in doubt, wear gloves. So, okay. Next thing. So how else can you prevent? Well, by knowing the chain of infection is really important. Because you can break that chain of infection. So if you know the mode, or if you know how it moves from place to place, you can go ahead and take care of that. One of the things that we had problems with in school nursing is mothers would come in just livid because their kid got lice. And they would want to have the child removed from the class that had the lice. The reality about lice is, first off, you don't die from lice infestation, so, you know, we need to get a grip here, you know. The other thing is that it's transmitted by, the lice has to be next to you, okay? So there has to be a way for the lice to jump to you. It doesn't just go across the room, okay? The other thing is it doesn't like to stay on surfaces. It likes to be on humans or animals. So these are things we know about the lice, right? So this is knowing your chain of infection helps you. So I could say to the family, say, look, once all the lice is removed, there's no way, and we're not letting the student back in if she has any lice, there's no way that your child's going to get it. Now, my daughter came home with it 3 times, and that was because they would put their heads next to each other and talk, or they'd share hats, or they'd share brushes. And so once we stopped that, we stopped the lice infestation. So it's just looking at that. So chain of infection is very important. Also, Good professional practice, okay? Again, clean equipment, hand washing, wearing gloves, keeping up your immunizations, wearing a clean uniform daily. And I really recommend, it used to be a rule, when you came out of the hospital, you went straight home and you changed into regular clothes. You did not go out to the grocery store and get your food. You did not go to a restaurant in your uniform. That was a big no-no. The thing that's happened, though, is many people wear uniforms that aren't working in infectious areas. They are, let's say, working in dentist's office, or they're working in a medical reception as a medical receptionist, and they're wearing, or they're working with dogs and cats, and they're wearing, and so they're not really truly working with the infectious diseases that we do in the hospital. So we don't always know when a person comes into the restaurant or into a grocery store whether they really are having that contact. But we need to do, as professionals, realize that yes, we did come in contact, and we need to go straight home, get rid of those uniforms, and take a shower and get cleaned up and make sure that we don't use those, that we wash those clothing. So wear a clean uniform, be a role model for health and hygiene. Don't come to work when you're sick. Easier said than done. Do not wear gloves outside the patient's room. Consider all patients to be potentially infected and act accordingly. Okay? And then, of course, utilize your standard precautions for all patients. And then also get to know your infectious control nurse or doctor at your facility and drain their brain whenever anything's coming through. And that's really important, having a doctor or a nurse that is doing this, that keeps you up to date. Some hospitals are very strong in this, and others are very weak in it. And so I'm always unhappy when they're weak in it, you know. So that means that we as individual nurses have to really stay up to date. Other things that we need to do is we need to do health promotion. That's teaching our patients about antibiotic use, how to use them properly. They have been abused and so badly over the years that now we have so many antibiotics in our, even just in our ground from waste, that it's just been a major problem. So we want to teach them about proper antibiotic use, being sure that once you start on the antibiotic, you continue and use it until it's completely gone, not stopping halfway. My sister-in-law loves to use about 5-7 days of her 10-day antibiotic. She doesn't, not as much now because I nag her, or she lies to me now and tells me she doesn't do it. But anyways, she'd use it then, and then she'd keep the rest of it, and so then the next time she'd come down with an infection, she'd use the rest of it. That is not what we want to do. What ends up happening is that virus or bacteria, well, and of course we shouldn't even be using antibiotics for viruses anyways, but let's say the bacteria, it then, after the 5 days, then it stays dormant for a while, but then it mutates, and now we have a more virulent bacteria. So we cannot, we have to really do a lot of education here. Okay, we want to talk to them about not self-treating themselves with antibiotic, and yet as I say this, my daughter-in-law used her eye antibiotics that she had left over for her conjunctivitis last night. I didn't even say anything. I just said, okay, now let's go back to do your warm compresses, and if it doesn't go away by, you know, then go see your doctor and get some antibiotics. But anyways, and of course, inappropriate use of the antibiotics. Many of the doctors have been forced to give antibiotics to patients. Not so much recently, because I think we've educated well enough. But there for a while, a patient would come in and say, I want antibiotics. I think, you know, and the reality is that the virus of a cold lasts 10 to 14 days. Up to 3 weeks, you're still having symptoms. So giving them an antibiotic, they usually tend to come in around 10 to 14 days. They're just fed up with it. They want an antibiotic, but it's not going to work for a virus. So we really have to do some education. And the doctors, I think, are getting better about it. Lack of compliance with treatment, we want to talk to them about. We want to encourage them to know that colds and flus are caused by viruses, and antibiotics are not going to help. Antivirals, maybe, but not antibiotics. We also want to identify the high-risk patients. High-risk patients that we have are, of course, the very old and the very young, any that have chronic diseases, our immunosuppressed patients. We talked about this earlier when we talked about host factors, but I'll go over it again. Anyone that has on medications such as corticosteroids or on frequent antibiotics or on chemotherapy, we know they're going to be at risk for infections, so we want to intervene with them. Any patient that has a procedure or stays a long period of time in the hospital is going to be at risk for infections, any type, infections or hospital-acquired infections. So what can we do? What's the treatment for our patients? Okay, first off, we need to assess our patient. So what would you feel are the most effective vital signs to do that would help your
temperature.
Temperature. That's the big one. And until they get that, you're not going to see any of the others change. So the temperature comes, then we might see the heart rate go up, we might see the respiratory rate come up, but typically the temperature is our first one that we're looking at. You don't usually see the BP go down or give you trouble until they're septic. So that's what we're going to be looking at, is that temperature and then subsequently the heart rate and respiratory. We're going to also try and assess when were they exposed to an infection and what kind of symptoms do they have. As far as symptoms concerned, the typical ones that we see first off is we see the fever, we see inflammation, and we will see the lymph nodes enlarge. So we'll be looking at lymphadenopathy. I hate that word. Such a long one. We also should look at the skin and the mucous membrane, see if there's any kind of rashes, any kind of changes there. And of course, we want to look at particular labs. We're looking at the WBCs, and we're going to talk about that more specifically on a later slide. Transmission precautions, we certainly want to assess and see if we need to put those in place and put them in place. We want to look at other things that we can do for this patient besides putting in transmission precautions is also trying and promote healing by their nutrition. So we want to give them a well-balanced diet, certainly one that's high in protein. We also want to make sure that they're hydrated. Another item that we can do for our patient in the care and treatment of an infection is good hygiene. What a difference good hygiene makes on so many levels. Studies that have come out, hygiene is a huge part of not only preventing infection, but also making a patient feel good. But we found just doing oral care for our patients with pneumonia, how much we've been able to diminish it, and if they have any kind of secretions and they have a trach or a ventilator, just doing oral care has prevented the incidence of pneumonia. Who thunk? Simple things. Okay, so hygiene we want to maintain. We also want to encourage rest periods. Medications that we would look at giving to our patient with an infection is certainly the antimicrobials, and also the antipyretics. With the antimicrobials, we'll talk about it more specifically on another slide, and we're going to talk about antipyretics just in a second when we talk about cooling measures. So when we look at cooling measures for our patient, it was typical 20 years ago for us to give, when a patient had a fever, is to cool them down. We would typically, if they got a temperature, we'd immediately give them the Tylenol, and we would immediately start cooling them down. Now they have found that fevers are recommended to allow them to, it's recommended that you just allow the fever to run its course, that we don't intervene, because what they found when a patient has a fever is that it actually interferes with pathogen growth, and it also inactivates pathogen toxins. So all these antigens that are coming into our body, the fever actually slows them down. which is interesting. It also encourages and affects a more intense immune response. So our body is reacting, our immune system is reacting more intensely based on having a fever. It also causes the person to slow down. They don't feel so great. They don't have much energy. So it makes them stay home and stay in bed. So these are good things because we want them to conserve their body energy so they can fight the infection. So we are now recommending that we let the fever go. Now, if it gets too high, then we will intervene. If the patient's complaining too much, we'll intervene. If the patient, like especially our young children, sometimes get febrile seizures, sometimes we'll intervene. But in general, most of the febrile seizures that occur with children, they outgrow them. It's really more a problem of the child and the family getting distraught over the seizure, okay? But there's a point where we will intervene. But we know in the back of our mind that we really want to let that fever work. It's miracles, okay? So trying to stay away from that. And that was the hardest thing in the world for me to do. With my daughter, when I had her, we were cooling them off, so I'd cool her off. And then when my son came around 7 years later, we weren't cooling him down, and I had the hardest time not wanting to put him in the shower and cool him off, or a bathtub and cool him off. It was very hard. So, but it is beneficial. Okay. Next thing, let's talk about the different lab tests that we look at. The ones that we're looking at primarily, and I'm going to go over this very briefly. This was one of those ones that I have a handout that you should have filled out before you came into class, but also we'll go over it specifically here. And when you look at this, also a lot of it was covered in the lab workshop that I did that you should have watched before the peri-op. So let's look at this. First off, some basics. Remember that when you look at a lab, or when you look at a history and physical, and they say, let me see, when they say blank pinia, that you need to remember that means low. Okay, so whatever is here is going to be low. And then if you see cytosis at the end of the word, then you're going to see that's going to be elevated. So typically what you'll see here is the most common ones we see is neutropenia. Okay, and neutrophils is what that stands for, okay? And the other one that we typically see here is we see the leukocytosis, don't we? But you can see thrombocytopenia here, thrombocytopenia. So we know that the platelets are low there. So based on these medical terminology, some of you took that class, some of you didn't. Some of you still remember from physiology what all these different things mean. Some of you need to review, but you really do need to review. You need to know what these terms mean as far as, because it's very common, you'll see in your H&P, they'll say, oh, the patient has neutropenia, or they have leukocytosis, or they had thrombocytopenia. These are the most common ones that I see. But it's essential that you just kind of remember, penia means low, cytosis means high. So let's look at the different parts of a WBC differential. Okay? So when you look at that, we see monocytes, granulocytes, and lymphocytes. Those are the three main ones. We talked about those when we were looking at immunity when I wrote out the components. So monocytes, what is their role? Their role is to respond to inflammation and to act as a macrophage. I don't worry certainly I don't want them to be low, but the most common thing that we see and when we're working with patients is they're elevated. And when they're elevated, this is a sign of chronic infections and chronic inflammation. So what you'll typically see me do when I'm looking at my labs, if I see my WBCs are elevated, of course, that immediately tells me something's going on. Or if they're low, that tells me something else. But when I look at my differential, I don't tend to look at my differential, to be perfectly honest with you. If I work in an area that I'm doing a lot of chemotherapy, or I'm on an oncology floor, or I'm on a floor that works with a lot of immunosuppressed or autoimmune diseases, I'm looking at my differential. But most of us aren't. So that's why I don't require you to do your differential for me when you're doing your labs in clinical. But if you had a patient that had chronic lymphocytic leukemia, you would need to look at your differential because it's so specific. If you had a patient, oh, I won't talk about that. That's off track. So anyways, I'm going to give you this general information, and as you become more advanced in your practice, you'll utilize this more. Okay. Okay. Neutrophils is another type of, and let's see. I think that's the monocytes all by themselves. Granulocytes have neutrophils. Did I put this on the next page? Oh, I did. See, here it is. So here is the page. I redo this every single semester, and so I always have to laugh at myself. How did I try and redo it this particular semester to make it more clear? And this will be up on Blackboard so you can look at the specifics. But there you go. Monocytes, they're a different type of cell, and I talked to you about that. Neutrophils, on the other hand, neutrophils, eosinophils, and basophils, they're all granulocytes. So when we look at these, the neutrophils are your first responder. So the minute we get any kind of pathogen come into our body, that neutrophil is going to respond. So we'll see it elevated in acute infections. And when it's low is when we get really worried. I tend to see this with my chemotherapy patients, my cancer patients that are getting treatment. We see it with prolonged infections. But with this bone marrow suppression, we really need to be looking at what number is that neutrophil. And this is one of those ones that if you work on 2P, you really need to know these numbers. So a mild neutropenia means that it's less than 1,500. Severe neutropenia is less than 500. So when I see these numbers go down, I know that this patient cannot fight off infections because that's our first responder. And if it's not responding, my patient's in trouble. So we put this patient immediately on what we call neutropenic precautions, which means we are protecting the patient from us. Okay? And so there's a whole protocol with that you'll get to know more about in 281 when you study oncology. Eosinophils, another granulocyte, limits the inflammatory response. Typically, I get most concerned about looking at it, seeing when it's elevated, usually with allergic responses. Any of our hypersensitivity responses, I'll usually see the eosinophils up. Basophils, another granulocyte that we see, is part of the inflammatory response. The interesting thing about this particular white blood cell is it acts on the blood vessels. It actually dilates them. So what we end up seeing is when a patient has any kind of elevation with basophils, there's some kind of inflammation going on, some kind of hypersensitivity reaction going on. Lymphocytes, lastly on our differential, is absolutely essential. We know that for our immune system because we were talking about T cells and B cells in our lymphocytes. So it's essential for our specific immune response. We see it can be low when we have our patients that have any kind of neoplasm cancer, and we also see it with our patients that have immune deficiencies. We see it elevated with acute viral infections. So when you see anything elevated or low in your differential, look at it and see if it makes sense for your patient. I don't usually make you write it up, but I do encourage you to look at it and say, okay, wow, that's interesting. Oh, the eosinophils are up. Oh, and they've been having problems with asthma, or they've been having problems with they have a latex allergy or something like that. So maybe you'll see a connection there. Sometimes you do, sometimes you don't. And that's why I don't have you write this up, because I think it takes a little bit more advanced practice, and I think you'll get better about it with each semester. Okay, moving on. Other tests that we can do for our patients are cultures. This is where we want to determine what the infecting organism is. It's so important that one of the criteria that's coming out now with treating infections, especially now that we know that we're just not developing antibiotics that are able and antivirals that are able to compete with these wonderful organisms that are able to mutate so quickly. It's such a statement about how bright they are, really. But it's not good for us that we aren't able to come up with things to fight these viruses and bacteria. But the cultures will tell us specifically what that bacteria is, and then it will identify with the sensitivity which antibiotic is specific for that, okay? So it's important that we get the most specific antibiotic for this patient. That's why sometimes you'll see after the culture and sensitivity comes back, the doctor will change the antibiotic that they had to a more specific one. The other thing that we also will see sometimes too is there's maybe a cheaper alternative for the patient, especially if they're going home, that we can put them on. You have a choice of 3 different antibiotics, and one is going to be less expensive than the other one. So that would be another thing that we see going on here. Another lab test that we look at is the C-reactive protein, or CRP, I'm sorry, CRP. This is a special type of protein that's produced in the liver, and it is present during episodes of inflammation or infection. So any acute inflammation or infection will show an elevation in our CRP because normally there is no CRP in our blood. So when you see that elevated, we know that there's something going on. So we want to look at that. It also can be a reflection of a chronic inflammation as well. We see this in our irritable bowel syndrome patients, and we see it in our rheumatoid arthritis. We can see the CRP be elevated. But it really isn't specific in that you can tell what that infection, inflammation, irritation is. We just know that it's going on. So we can't suppress it. Well, it is suppressed when our patients are on corticosteroids. So if, let's say, you have a patient that's normally taking, and this is a great example, you know, your rheumatoid arthritis may be taking steroids to diminish it, then we're not going to see that reaction here. So we can mess with our results here. ESR is another blood test that we can do. Erythrocyte sedimentation rate, ESR. For the longest time, I just knew it as ESR. Many times, a lot of us nurses, we just work with these so long that we forget what they originally stood for. But this is a rate that indicates inflammation and increases in many diseases. But again, this one is nonspecific. It doesn't really tell you specifically where the cause is or the location of the inflammation. But sometimes they use it as a way to diagnose. I've seen them using it, you know, like let's say they have a patient and they'll say, well, the ESR is up, so that was indicative of that particular disease. So they'll use it as helping them to diagnose. Antibiotic peak and trough levels is another one. Have you ever used peak and troughs in your experience? Okay. This is typically, we see this more in the ICU, I think, than any area. But sometimes you'll see it out on the floors. This is where we're monitoring and making sure that we have a therapeutic level of the medication that we're giving. So what we'll do is, and the big trick with this is timing, is we're going to check for the peak of that medication. Usually we'll measure it an hour after an IM injection, which so rare we do that anymore. It's mainly 30 minutes after an IV medication. So let's say I give my vancomycin. 30 minutes after that, I've got to get a blood draw on this patient to get the peak level, okay? Then the next thing I want to do is I want to get a trough level. And the trough level is the lowest level, and it's measured before the next scheduled dose. So let's say I gave the vancomycin at 10 and let's say it's at 10 a.m. every day I give it. So I would need to do my peak at 10:30, and then I would want to the next day, somewhere around 9 a.m., 9:30, I would want to get a trough. This now tells the doctor, is he or she got the right amount of medication running for this patient. And this is most important with patients that we consider sensitive as far as they could have kidney damage or hearing damage from the medication. So we want to get it as finely tuned as possible. I see this a lot with our pediatric population. We don't want those medications are so toxic to them, and we want to give them the maximum amount we can give them to help them fight the infection, but we want to give them the least amount because we don't want the damage from that particular medication. So, timing. It's really nice if they have a arterial line in place, or they have a central venous access line, because then the nurse can just go in whenever she wants to do it and just pull it and get it sent off. But it's when you have to wait on lab to come up and draw these for you, it gets really messy. Okay. Next thing we want to look at is the different antimicrobials. Now I know Susan should be covering this as well as far as the antibiotics, so I'm going to go over more generally and more specific to nursing function. So antimicrobials, they are anti-infective drugs that are capable of killing or incapacitating the pathogens. The problem with this when we're talking about antimicrobials is the terms. We have people talking about antibacterial, antimicrobial, antibiotic, and they're often used interchangeably, but they all sometimes mean a little bit more specific, but most of the time people are saying them generically. And so you can't, sometimes people will say they took an antibiotic and we knew it was an antiviral. I mean, because they're not the same thing. So we need to, but those three terms are pretty much the same together. Okay. Different drug classifications that we have, they are classified in these different drug classes, and because they function very similarly. It's really important as nurses, if you want to be successful in pharm, is to be able to know these different classes. So then when they add another one, you can kind of say, well, I know cephalosporins, and this is a new cephalosporin, so I can go ahead with that. So these are the typical drug classes that are out there: your penicillins, your cephalosporins, tetracyclines, your macrolides, your aminoglycosides, and your quinolones. I can never say these right. Quinolones. I'll say it right when I practice, and then when I get up in front of you guys, I'll say it wrong. So let's look at how to use this. First off, prophylactic use of antimicrobials are really not encouraged. We shouldn't really be using them to prevent an infection. But the reality is there are certain situations where we do. Surgery is one of them. It is. So antibiotics are given to prevent an infection and given in post-op. And they've done a lot of research and found that if they do it for just X amount of time, they can prevent an infection and not put the patient at risk. But there's most of the time prophylactic use is not a good idea. Before we start any antimicrobial therapy, we should do what? Get a culture. So we want to make sure, like I said before in another lecture, that the doctor truly didn't want a culture to be done before we started. When we talk about adverse reactions to antimicrobial, I divided it up into three major adverse reactions that we can see. We see allergic reactions, which can be different levels of it. We also see super infections, and we see organ toxicity. So let's talk about, in the adverse reactions, let's talk about allergic reactions first. When we look at those, they can be mild or they can be severe. So when we look at mild, The most common thing that we see is a rash, and we can typically treat this with an antihistamine. Okay, I certainly have had my share of allergic reactions to antimicrobials. I am allergic to penicillin and I am allergic to sulfa. I get a rash with the sulfa and I immediately stop the antibiotic and I take an antihistamine. And what's my favorite antihistamine? Benadryl. So as far as penicillin, I get actually hives, so it gets a little bit beyond the rash. It gets what they call urticaria, where you have that upraised level of a rash. And so I definitely stop that one as well and do the Benadryl. But that one worries me more because that might end up where if I ever took it again, I would be in trouble. I don't ever take penicillin. Okay. So the thing that we have to worry about is that a patient that doesn't know that they have this reaction or we give this medication and they've told us they do have a reaction to this, is that they could go into anaphylaxis. So a severe reaction to an antimicrobial would be our anaphylaxis. Again, this is very similar to what we talked about with vaccines, is that shortness of breath or itching might be your first symptom, and severe reactions can occur within the first 20 minutes. You usually don't see it too much farther out than that, but they have said that it can even occur as late as a day as far as anaphylaxis. In my personal clinical experience, when I've seen it happen, it's happened right away within the first 5 to 20 minutes of me giving that antibiotic. Okay? The treatment, again, is very similar to what we talked about with our vaccination reactions, is we need to give that epinephrine. Is it, what is it, 1 to 1,000? Yes, not 1 to 10,000. 1 to 10,000 is the kind that we give for cardiac issues, and that's a whole nother game. We're talking about a whole nother use of epinephrine, is where we use it for cardiac issues, and that is 1 to 10,000. The kind that we're giving here is 1 to 1,000, and that is for allergic reactions. The other thing that we need to administer is an antihistamine, so Benadryl is certainly the drug of choice. And then if they're still continuing to have problems, we look at bronchodilators. Sometimes we'll have respiratory therapy come in and give them a breathing treatment to try and open up those airways. But typically the first two are the most common that work for me and the ones that I've dealt with. Going on, other types of adverse reactions that we see with antimicrobial besides the allergic reaction, we see superinfections. And you talked about, you've been seeing a lot of the C. diff. So let's talk about that. Superinfections are a secondary infection. They're also called a healthcare-associated infection, and it occurs when the normal flora is disturbed during antibiotic therapy. C. diff is the classic one that we see, okay? C. diff is usually a superinfection, but it can be also a nosocomial or healthcare-associated infection. And I hate to confuse everybody on this one, but C. diff is, in this, we're going to talk about as superinfections. But we do know that there's spores there. And so those spores can be on a surface for a long time. So you or I could take it into another room and give it to another patient. That would be a HAI, a healthcare-associated infection or a nosocomial infection. But most of the infections that we see are superinfections. Hard to believe. You would think that we would be just spreading it from room to room. It's hard to believe we don't. But luckily, most of the time what it is a superinfection. So let's talk about why it is a superinfection. Superinfections, the statistics about C. diff is it's been epidemic since 2000. They have about 14,000 deaths per year. And actually, the World Health Organization declared it a 1 of 3 threat. What did I mean when I wrote that? 1 of 3 threat. I don't know what I was meaning when I wrote that down. I will clarify that one for the class next week. Anyways, It's found, C. diff is actually found in 33% of all hospital rooms. So if I have 3 rooms, one of those rooms has C. diff. I mean, we're just talking about odds. So if I have 30 rooms on the floor, 10 of them have C. diff. I mean, that's what we're talking about. But surprisingly, a minority of the patients are colonized. So I guess they must be able to fight it off. But this is the pathophysiology that we talk about with C. diff. Okay. It's caused by the use of antibiotics. The classifications that are most common causing this are cephalosporins. Clindamycin's another one that likes to do it. What happens when we take these antibiotics? It alters our GI flora. And when it alters it, what ends up happening is there's a toxin from the bacteria that makes you sick. So when we alter this GI flora, this C. diff grows out of control. And then the toxin from that bacteria is actually what makes you sick, not the bacteria itself. And that toxin causes mucosal injury and inflammation of the GI tract. The incubation for this particular bacteria and problem is 3 days. It's difficult to treat because it's resistant to the quinolones, which is the drug of choice for this particular bacteria. And it's also difficult to treat because the C. diff sheds spores in the feces, and then those spores live on the surface for a long time. So that's one of the reasons. Most of these patients will get better, but about 20 to 35% will continue to have recurrent episodes. So that's what we're seeing as this recurrence coming back. Signs and symptoms for this are a watery diarrhea and leukocytosis that's very high. So their WBC counts are very high. Plus they can have more problems than that, but those are the most typical. What kind of symptoms have you seen with the patients?
Smell.
Oh yeah, it's smelly.
Frequent diarrhea.
Yeah, very frequent. And then you...
actually causing a lot of incontinence issues.
And then you have all the other issues that can happen. The excoriation of the skin, a UTI that can then happen.
Yeah, then now you're getting different types of infections.
Yeah, so the secondary infections will come. So what can we do? Collaborative care and preventative care. Well, the first thing starts with using antibiotics wisely. That was what was really stressed in this one seminar I went to, is that we really have to use our clindamycin wisely. Don't just blanket use it. Really restrict it. And they're saying restricting the use of clindamycin, especially being careful about vancomycin and phytoxamycin. I haven't seen that one out there. I guess it's an expensive one. So we just need to be very wise, and this is where our infectious disease doctors need to be very prudent about which antibiotics are the best one to use. We need to be using hand hygiene with soap and water, gloves and gown, good room cleaning, especially this is where housekeeping really need to come in afterwards and be cleaning these rooms very wisely. Huh?
Bleach.
Yes. Good room cleaning, cohorting patients, and longer courses using tapered doses of vancomycin have been found to prevent recurrent episodes and allow the intestines time to restore its normal flora. So they're finding what they're starting to do is they're starting to do like doing smaller doses of vancomycin if they have to use it, or hitting it with the vancomycin and then allowing the GI tract to rest and then coming back in. So they're coming with a lot of different sorts of ways that they think might work for it. But the main thing is knowing that all these antibiotics we're giving them are getting them in trouble with C. diff. So another thing that they say in collaborative care that might help is probiotics. You know, these are our yogurt, there's actually products that are made that are called probiotics that we give. Actually, it's got kind of a mixed review. They find that it does really work with most patients, but they're finding that they're having complications with immunosuppressed patients. And I can't remember what it said about that. So know that the probiotics may not be it's one thing to consider. Another thing that they're using is fecal transplants. Have you heard of this yet? You haven't? Okay. This is actually growing in popularity. Okay. It's not it's not monitored properly, so we're not really knowing what the results are, but they're saying where it is being monitored, where there is a person, a physician that is doing it, they're having 90% cure rates with it. And what it is they literally go up and do a colonoscopy, and using healthy stool, they implant that healthy stool into the GI tract. Yeah? Oh, we're rolling our eyes for those of you that don't know that. You probably are at home too if you're listening to this. But you think to yourself, where did they come up with this idea? Well, they've been doing this with horses for a long time. And my daughter-in-law, who is an agriculture science graduate student, tells me, yeah, they've been doing these for a long time. So this is not a new thing in veterinarian medicine, but it is certainly new for us. And so having healthy stool, and it's working. And I think if you, and I know you, Nick, have had experience with these patients with C. diff, at some point you'd probably be willing to do this. No?
I mean, yeah, it's not.
Whose stool would you take? That's the question.
Like your wife's?
Yeah, I don't know. I'm going to have to go back and talk to my husband about this, see if this is some...
Change your relationship.
It's going to
Share a little too much.
A little bit too much sharing. Oh, Lord. Maybe an anonymous donor. Oh, gosh. Anyways, but what they found is that it does reestablish healthy flora. Gosh. All right. Let's talk about organ toxicity. Many organs are involved in the drug metabolism and excretion of these antimicrobials, but the liver and the kidney are the main ones. We really have problems with, especially with our elderly population, although if you were working with peds, I'd say I see more caution related to peds when we're dealing with our antimicrobials, making sure there's not organ toxicity. But since most of your course with us and most of my interactions are with the adults, it's the elderly that I'm really watching for here. When I'm dealing with my elderly population, how can I figure out whether I'm getting organ toxicity? Well, that's by looking at my liver enzymes and by looking at my kidney function. So my liver enzymes, you can look at your SGOTs, your SGPTs. I can also look at my kidney function, BUN, and creatinine. So I'm looking to see how well they're functioning, if they're doing okay. All right. Next area, what can we do? Some of this is repeats from what we've said before, but let's just move through that. Some of the things that we can do is, first off, when we're dealing with a patient that is on antimicrobials, be sure to know their medical, surgical, and drug history that they've had, including any herbal or alternative therapies that they might do. So you need to have that background to make sure there's no conflicts here with your patients. You need to always, like I said before, and I say again for I think the third time, is that you need to obtain specimens prior to any kind of antibiotics. So you want to do your culture and sensitivity.
Quick question about that. I mean, I know that is true, but is it just because if they're giving like a broad spectrum antibiotic, it's going to mess up the culture completely?
Yes. So what they want to do is, but I'm finding that more and more of the doctors, they know exactly what they think the disease is, and so they are going to go ahead right away with that particular antibiotic. So many times when a doctor orders a antibiotic, if I know them and I know they would have told me to do the culture first, I'll just go ahead with the antibiotic. But some doctors I don't know, and maybe they've just come into the ED and it's a new infection, that is definitely a patient I'm going to go over to the doctor and say, do you want me to culture it before we go for it? Because once we start the antibiotics, we're not going to have a good picture at that point on, okay?
Seems like when they show up on the floor, you see the broad spectrum already ordered, and you have the culture at the same point. Or I mean,
you have the results coming to you.
Well, no, to see the CNS.
Yeah, so you're seeing the CNS coming back to you a few days later, and then that's when you might see the doctor making it a more narrow antibiotic. But they are encouraging to start with the narrow antibiotic now, and narrow spectrum rather than the broad. Okay, we want to observe for allergic reactions. We talked about that, especially within the first 30 minutes. We want to monitor their renal and hepatic function. We want to monitor them for superinfections. So we want to also go ahead, again, talking about those probiotics. Certainly yogurt, buttermilk are the old style probiotics that we used to do, but also we actually have supplements that we can give. We want to watch their response to therapy. And so what do we expect if the antibiotic is working successfully against an infection? What should we see?
If the what? Sorry, I was sorry.
If the infection, so what are the signs and symptoms of an infection? So we should
decrease fever.
Exactly.
Yeah.
So we should see their fever going down. Their WBCs we know were elevated when they started. We should see them coming down. We should see their appetite improving, the malaise should be ebbing, and we should see absence of the symptoms depending on whatever the disease is. So this is how we know that the therapy is working. And of course we want to always provide education. So making sure that we tell them to take all their medication. If the medication is not working or they're having some problem with the medication, they need to come back and contact that healthcare provider so we can make a change, not them just stop it. And for those of patients that are allergic, we need to make sure they wear alert bracelets. I'm going to stop here because it is time. And we'll go over antimicrobial resistance next week with wound care. And wound care doesn't usually take the full period of time. So thank you very much. I hope you're enjoying the BRN meeting, except for Nick, who's been tortured by me. Nick's saying hi. Say hi. And we'll talk to you next week, and I'll update anything or answer any questions that you might have related to this. Thank you.